I'm going to present Judith Landau. Dr. Landau, who's a child, family, and community neuropsychiatrist and former professor of psychiatry and family medicine, has specialized in mental health, trauma, addiction, and co-occurring disorders for 40-plus years, exploring how to facilitate resilience and healing for individuals, families, and communities through collaborative care. Developer of the evidence-based best practice transitional family therapy, TFT, the first integrative family services model, invitational intervention, which is the ARISE comprehensive care system, which you'll hear more about in the next presentation, Link Community Resilience, and Life, which is Link Individual Empowerment, all based on the TFT model. She has over 200 publications, has taught in over 100 countries, and trained over 2,000 people in ARISE. A senior Fulbright scholar and recipient of numerous awards, she has served as consultant to the World Health Organization, NIDA, NIAAA, and the CDC, and several international governments. And the name of her presentation today is a multi-generational, cross-cultural approach to trauma, resilience, and healing.
Thank you, John, and Dr. Brett. And thank you to Gruben Foundation, Salve Regina University, and the hospital. And it's a tremendous privilege and pleasure to be here in a community setting with a community that is working collaboratively for the good of the community. So it's a very special occasion for me. And thank you, Diana, for making this happen. So how is the sound in the back? Good afternoon, everybody. How is the sound in the back? Do we need to increase? We need to increase, please. I think we're hearing increase on my right and good on the left. So I would go with a little increasing so we don't deafen the ones on the left, my stage left. How is that now? I'm going to keep talking until I know you can all hear me. Are we good now? Yes? Thank you. Okay. I do not have any relevant financial relationships and conflicts. And after our wonderful morning, I'm going to go very briefly just through some of the growing global concerns that we're all dealing with, just to bring us back to what Christoph shared with us and to focus us on where I'm going to be going. And I'm just going to run through these because I think one of the things that strikes me is that every decade or so the concerns change, and they have never been as global as they are at this point. And there's a debate about whether they're really a huge increase in concerns or whether it's part of our global awareness and global community, and I think it's both. You know, that we were never invited to sit watching a war before television changed and so on. That we're seeing a huge amount of mass trauma, much worse in the United States than in any other country. We're seeing more and more climate refugees with the climate change that some people deny is happening. And the United Nations estimates that there'll be 200 million people displaced by climate change by the year 2050. That's almost the equivalent of the entire population of the US. And we're already seeing huge amounts of climate refugees. And the climate is changing at unprecedented rates. There's this one. Every refugee and forced immigrant population has an average of a 30% increase in addiction, mental health issues, heart and lung issues. So if we watch that increase in numbers of refugees from all of these mass disaster of every kind, we're going to be dealing with an enormous population of displaced people. We're also seeing an increase in epidemics and pandemics, and random traumatic events. And random, unpredictable acts of violence are much more terrifying and much more disruptive than when one gets used to living in a war zone. So, for example, the areas of the world where there is constant war, like the Middle East, people become relatively inured to the violence and are not having nearly as much of the sequelae, the consequences with addiction and heart and lung disease. So that's a side benefit, but I don't really see it as a benefit, and I hope we don't get so used to our random acts of violence and the school and church shootings that we no longer respond. We're also seeing huge increases in political turmoil. And concurrently, one of the things that worries me most is that we're seeing decreasing attention to ethics in behavior at every level, and a decrease in the way in which people consider each other in public spaces, in schools, in workplaces, where we're seeing much more of a me, gimme philosophy that seems to be directly correlated with the increase in violence, and then again with increasing disconnectedness from community, which is why I'm so thrilled to be here, because you're all taking steps to ensure that that doesn't happen in your community. And concurrently, we're seeing an increase in risk-taking all over the world. If I stand here, can you still see the slides? Yes. Okay, good. So this was a conference I was at recently, the World Federation of Therapeutic Communities, and Gilberto Vieira, Chief of the Drug Prevention and Health Branch at UNODC, went through the vulnerability factors for substance use disorders, very much what both Christoph and Constant touched on, that we're looking at the biopsychosocial cultural issues that impact us. So we have prenatal stress, all of this leading to epigenetic changes in the way in which genes are expressed. The genes themselves don't change, but the way that they're expressed does. And so we're seeing all of the ACE factors, early chronic stress, etc., along with exposure to drugs in early teens. For example, parents who give their kids liquor to leave the house or drink in the house, those kids are much more likely to use and much more likely to become dependent. So we're looking at all of the ACE factors, but we're also looking at use and environmental factors that are much broader than just the ones that have happened directly to the child. We're seeing a huge increase in meth right now. We're still talking about opiate deaths and the opiate epidemic, but we're concurrently seeing, both from Mexico and from Afghanistan, we're seeing a huge influx of meth, and many more meth deaths. And we're also seeing alcohol deaths in young men with liver disease much, much earlier than they ever did. So, you know, I absolutely believe we need to be dealing with the opiate epidemic, but I think we've got to be really careful about it's not blinding us to the fact that we're also looking at all the other addictive substances. Has crystal meth hit here yet? Very little, yes. You're seeing it?
Yes.
Yeah. Yeah. You know, the challenge is that it's so cheap and it is so devastating. And so just remembering that this was last year's number of past year, it was published last year, but it was the 2016 figures. We're always a little bit behind with data collection, but really important not to forget that all the rest of them are still out there. And then we have our people.
Sorry, the back is just having
Okay, thank you. Let me know if my voice fades, because I sometimes get excited and then my voice drops. So just let me know. Thank you. We're also seeing an increase in poverty, physical and emotional abuse and neglect, which, as we've talked about, as Christoph and Constant talked about, are precursors of self-injury, risk-taking, and suicide. And even our wealthiest communities around the world have poor communities nearby that are living in food deserts and deprivation. And I think sometimes it's hard to remember, and again, that's why I'm really glad about the effort that's happening here. So to look at what happens when we have all of these consequences is that we see people becoming much more vulnerable during transitions. And those transitions can be celebrations or they can be devastating losses. Even the fun transitions make us more vulnerable. And traumatic transitions, obviously, are much harder than joyous transitions. And we see increases in stress, depression, and suicide. And the first break of mental illness, as well as substance use disorder and other gambling, behavioral compulsions or process addictions, and relapse in all of those. When there are multiple transitions for the individual, or the family, or the community around them. And I think sometimes it's hard to remember that we need to look not just at what's happening with our individual client, but with every member of their family, and what's happening in the community around them, because we all respond to our environment. Way back, I wanted to try and find out how many transitions we can cope with without running into trouble. Want to guess how many? 3, yeah, seeing that. So 3 or more tend to throw us off track, and I'm going to get back to talking about why that happens. Suicide is the second leading cause of death for people aged 10 to 24, and the majority of suicides are in young women. So, and they're not all related to drugs and alcohol. One of the things with ACEs is that it's very easy to count up and look at the scoring of an ACE assessment just for the client. What's really important is that the child can have the same level of trauma, same level of risk-taking, personal risk-taking, same level of depression, substance use, if the trauma... Oh, thank you. I'd get the mic
Sorry.
right. No, it's good. Just keep going. Seb, thank you. That's much better. What was the matter?
It wasn't you.
Phew, I couldn't understand why I'm talking so loudly and nobody can hear. Thank you so much. So if the parent or grandparent or even a great-grandparent had a very high ACE score, we can see the same problems in that child and that adult child growing up. So it's really important to take, as the two of them talked about this morning, to look at the longitudinal history and the environment. Because if we're only looking at our one client and what they've gone through, we're going to miss a great deal and not understand what's going on with them or how to help them. Because helping has to go across the whole system. So some of the, just to highlight some of the other things that we're all dealing with right now that are prevalent. You can all see this, right? I don't want to be showing slides that people can't see like I've been talking and not heard. Just trying to take precautions. And these are things that we are being bombarded with at this point. I see so many young people who have totally lost their self-esteem because of name-calling, bullying, or they've been on their video games and so on. And one of the things that I think I want to stress is that we talk a lot about adolescence, we talk a lot about early drug use. I've been seeing a series of little kids between 7 and 11 with extreme violence. You know, one little boy was 9 years old, and he'd managed to get in the kitchen, he'd managed to take one of the huge knives and had battered the granite to the extent that there was about $30,000 of damage in the kitchen. He had also broken down the kitchen cupboard doors. And when I spent time with the family, this had all started when they took away his electronic controls because they felt he was spending too much time with video games. And it had got to a point where his mother, who was smaller than he was locking herself in the bedroom to avoid his violence. And when I got to find out what had happened, his father, who never ever got angry, never ever hit him, was seething with rage because of having been beaten up repeatedly through his childhood by his father, who was in the Russian army. And the child was picking up on this inherent rage in his father without ever being hit. His mother was incredibly busy doing wonderful acts of in the community, creating community gardens and reading programs, but he was taken care of by a series of carers and very clear talking to them that he had become addicted to sugar by the age of 3, which was the way he was soothed, and why he was trying to get to the kitchen cupboard with all the sweet cereals and things. And he was addicted to video games by the time he was 6. And every video game, I said, let's look at your television. And this is not the only child where I've seen this. Look at your television, and there were 40-odd movies of it, which only 2 were family movies. The others were all violence. And we watched one avatar beat up another, and when the movie was done, I only let him watch 10 minutes of each thing. At the 10-minute mark, he got up, got into the pose of the winning avatar, and attacked his mom. And I'm just giving that example because I think so often we don't look at that longitudinal history and what's it all about with the family, clearly father needed a lot of help, mom needed a lot of help, and we don't ask what parents have done when the kids are tiny, very much the way that Christoph talked so poignantly this morning about the miss or unparenting. And all of this results in a decrease in connection to family, community, and the world around us. And our security depends on our connection. With that hypothesis, my team and I did a series of studies looking at sexual risk-taking compared with frequency of contact with extended family and knowledge of family stories across time, to explore whether our connectedness to our family and our culture are protective. And when people take sexual risks, they're invariably taking risks with substances or with driving fast cars or whatever their particular way is of desperately trying to get that excitement and the dopamine. The first study we did was with women in an STD clinic compared with women in a community setting. It was a community center, and obviously the levels of sexual risk-taking were different, but both measures held up independently and together, and both correlated with the more connected they were to family and culture, the less risk-taking. So then we went to a clinic of troubled adolescent girls, repeated the study, the measures held up again, connection to family, looking at frequency of contact with family members across generations, and then stories across time for connectedness to culture. And we then analyzed the stories for themes of resilience versus themes of vulnerability. And what we found was that the least risk-taking related to themes of resilience, which was no surprise at all. But the second lowest risk-taking was the kids with really horrible stories, vulnerable stories. And the highest risk-taking was correlated with knowing no stories at all. And, you know, when we think about the way that kids are fostered, adopted, and protected from the horror of their family stories, which is really dangerous for them. So what we then did was we went back and analyzed the content of the stories, thinking that they would be very different. But what we found was that there were the same stories of murder, substance abuse across across time, across generations, suicides, and so on. The only difference was the way that the girl and her family viewed themselves. Did they see themselves as overcoming? We're a family of survivors. We've gone through all of this, and I know if I do my work in the clinic, I'm going to be fine. Versus, you know, we've the same story. We've had all of this horrible background, and I know that no matter what I do, things will be horrible for me and the future. So from that, we started developing a way of working that was really looking for the positives in the stories, looking for the survival, working towards the strengths and not the vulnerability, helping the kids see themselves as survivors and their families as well. And families definitely influence outcomes. The kids that were talking about vulnerable stories were repeating what they had heard. The kids who regarded themselves as survivors were bringing the family philosophy along with hope. So getting back to transitions, every living thing is in transition and all families are in transition, and depending on cultural influences are either in or out of sync. And what happens when one member of a family or a subsystem in a family is moving at a different pace, or for example, we have an untimely death. The whole family gets shaken up because of that lack of synchrony. How many of you are familiar with the family life cycle? Individual life cycle. So this is just, thank you, this is a way that I really like of interpreting the life cycle as a spiral, because there are times where families come together, births, weddings, funerals, and times where we separate out, adolescence, reevaluation, and retirement. Which do you think when are we more at risk? When we're all together or when we're separating out? Separating out, yeah. So these are the periods. So if we look here, we've got a child being born, middle years of childhood, adolescence, marriage, courtship, childbearing, and now we have settling down with another generation while the grandparents are planning for retirement. Now, this was done in 1985, and it was done in a culture that you can immediately identify. So we never show our families and our clients this drawing. We do the diagram for them, their family, and their culture. But I'm using this one because that was the original, and it really lets us see that what might happen if we lose a child. This whole spiral that relies on a movement forward. This child, if the child dies in early infancy or let's say middle years, instead of going through the spiral, goes all the way to death, which throws the synchrony of the family because they're all imagining that child's future. And if we look at what they're picturing, one can really see it here, and working with this with families who've lost somebody really helps them put it in perspective. And the other thing that happens is this little one dies, what happens to the older kids? Do they fill in the gap? Do they suddenly become older because they've now got to take care of parents? And similarly, if we have a chronic illness happening with a young person, they're then reversing the life spiral and needing to be taken care of. And it doesn't just affect one small part of the family, it affects the entire spiral. So when we're looking at addiction, we need to be looking at where everybody else is, so that we're not just, because if we work only in one part of the spiral, we're going to throw that family out of sync with the rest. And if we do that, it's like taking a cog out of an engine and then putting it back and expecting it to fit, where nothing really functions well. So this was done in 1985. I redid it in 2015. And we're looking at a very different predominant life spiral. Modern medical science has given us an extra decade. Mandatory retirement in universities, for example, used to be 65. It's now 75 in many universities. And that extra decade, we can see, has changed what happens with our youth. Instead of going from middle years of childhood to adolescence, marriage, and courtship, we've got a whole new loop. Late adolescence, young adulthood, coupling, and then childbearing with or without marriage. And I get very upset when I hear people talk about failure to launch, where to me, it's not a failure to launch, it's a failure on our part to adjust to a major cultural change. And I think looking at things from the process, a perspective of transition, allows us to come in and work with the individual, if we're working individually, or the family, from a very different perspective. It allows us to look at the strengths in the family rather than labeling things as pathological. Because the minute we tell a young person that they're failing to launch, what are we doing to them? Right? Whereas if we talk about the cultural shift, the family starts to look at it differently, they start to be able to adapt. And the young person starts to look at, what can I do with this extra decade? How can I be successful? Rather than, why am I failing? And what's interesting, after I'd finished this work, this came out about the changes in population, which shows us very clearly how that extra decade has come in across the world. And we need to look at it as an opportunity. And how do we help families adapt to this? And it's really difficult, because for those of you who've had kids being raised and heading to college and wondering how one's going to pay for their college or support them doing it, and we're now looking at that extra decade, it's pretty scary. But we need to find ways of coping with it. So what we really want to do is we want to view our clients, their families, and the world around us from a positive perspective and build positive connectedness and avoid blaming. We did some work on language as a catalyst for change, and we're really horrible in the addiction world with using blaming language. And if we look at the dynamics underlying those blaming words and talk to people about those dynamics instead of using words that shame them, we can really start to change the way we view things. You know, I would hate to be called a codependent person or an enabling mother. And what is that really based on? It's based on fear of loss, on intense loving. No mother sets about doing something to damage her child. No husband or father tries to damage a spouse. And those behaviors are built into fear of loss. Loss of life, loss of person, loss of safety. So taking this a little further and really looking at how do we view things from the positive perspective of connection rather than the negative. So we want to draw on the family's inherent resilience rather than labeling behavior patterns as dysfunctional, because there's no question when people are called dysfunctional, it decreases their self-esteem, and when we're feeling bad about ourselves, we all have that little kid still inside us, that if you say that I'm bad, and I feel bad about myself, I lose my competence, I lose my capacity to act. So we really, it seems very simple, but we're living in most cultures around the world right now, except the indigenous cultures. We're living in a time where people blame themselves and blame one another, rather than looking for the positives and the strengths and the connection. And even with the brain, connectedness is interpreted as a reward by the brain and is associated with the release of dopamine. So that connection, how many of you have had that surge of pleasure when you get a hug from somebody you haven't seen for a while? You know, and thinking about that with our clients. You know, that word of praise rather than blame actually has an immediate release of dopamine. Right? Conversely, brain imaging studies suggest that the same parts of the brain are activated during social rejection and not just physical pain. Right? So if we're dealing with somebody who's found a way of self-soothing and releasing dopamine that's not good for them, If we blame them, reject them, that's going to drive them to look for whatever that self-soothing mechanism is. And what upsets me a lot is when I'm consulting to treatment centers, there are so many that are still blaming and shaming the patients or the families. You know, we talked about that a little bit this morning, that if one of the clients is in trouble, it's got to be that somebody was bad, rather than what's missing and how do we rebuild it. Social connectedness, similarly, is a basic human need. And what's interesting is the number of close confidants in the United States decreased from 3 in 1985 to 1 in 2004. And 25% of respondents said they have no one they confide in. And this morning, I think it was this, Constant mentioned, and I mentioned that it takes 5 members of an artificial support system, the extended ancillary system, to replace 1 family member. So imagine going through life without having somebody they can confide in. And what replaces that to give pleasure and relief and to feel like somebody regards us as worthwhile. An increase in loneliness, isolation, and alienation may be the leading reason that people seek psychological counseling. And so they find a therapist or a counselor, but it still takes 5 of those to replace 1 member of the natural support system, a close friend, a family member, a colleague, a teacher, somebody who is part of your daily living. And one of the things that's happening in schools is we're seeing an increasing burden on teachers. There was an article, we live in a small community of about 25,000 people in the Vail Valley in Colorado, and the school principals got together and wrote a lead article for the local newspaper about how they were spending their entire days as social workers, because there was so much pressure that the kids were in. The kids had multiple jobs, the parents had multiple jobs. They would come to school, fall asleep because they hadn't had enough sleep. They hadn't done homework because there was no parent to help them and they were too tired, or they were hungry. And this is just one community across our own country. And there are so many of them where this desperate need for survival at very basic level is not being met. A lack of social connection leads to vulnerability that then leads to anxiety, depression, antisocial behavior, suicidal ideation, and of course, whatever self-soothing mechanism they can find. Building and maintaining social connections requires a level of self-confidence and self-efficacy that many people lack because it hasn't been given to them as children, either at home or at school. And these are fairly simple things to change in our own communities. We have the capacity not to do it for the country or the world, but just in the communities around us. The work that we do, both Constant and I were raised in South Africa, where Ubuntu is the underpinning philosophy that I am defined, I am me, because you are you and because we are. And it is a different way of looking from the ego-driven, I'm going to be fine because I'm strong and I'm good. Looking instead towards how do we act towards others, how do we live in community, how do we behave as a full member of that community. And that's one of the underpinnings of my research on resilience and also the way that we work. So we see resilience as the capacity, hope, and faith to withstand major trauma and loss, overcome adversity, and to prevail, usually with increased resources, competence, and connectedness. And the individual's the integral unit of the family, and the family is the integral unit of the community. So our resilience depends on all of those. So what I'd like to do now is go on to talking about transitional family therapy and enough theory. It's an integrative approach. It was the first family model that really looked not just at the here and now or the intergenerational or the ecosystem, but at all of them. So, here and now, why now? What are the contextual history, themes, script, stories, and strengths that have come down the generations? And the history of the family and their context. So what is the history of that country, of that region? Have there been floods or famines or a company that closed down? When I was teaching in Rochester, we would listen to the news in the morning. And if Kodak had laid off people from work, we knew we'd have a flood of patients coming in to the emergency room, the heart clinic, psych, addiction, and family. And it was either the person who'd been laid off or a family member. But those things that happen in a community around our patients and clients are as important as what happens to them themselves. And that's when we see that huge increase in substance use disorder, process addictions, and mental health relapses or first breaks. So we believe that individuals, families, and communities are intrinsically healthy and competent, like every other living thing, with the capacity to change in constant transition, and typically coping well unless there are a number of transitions in a short space of time, and if those transitions are traumatic, and that families are able to access and utilize their strengths and resources unless they're cut off from their natural support systems. So the 5 keys to transitional family therapy principles: empower the family, community, and natural support system, removing shame, blame, and guilt. Reinforce connection to family and culture of origin. Focus on individual, family, and community healing and recovery. Remove the we-they dichotomy. In the old days, there was this sense that the medical profession and therapists were superior and different. Unless we're able to see ourselves as level, equal, just as likely to be running into trouble at some time as any other person, we don't form the bond we need, which is a collaborative bond where we're working as a team. We may bring our additional knowledge, but our clients and families bring their knowledge about themselves and their wisdom about themselves and their culture. And we have so much to learn, and it's so much more fun if we can work in collaboration rather than from a hierarchical position. And we mobilize and reconnect the extended natural support system. So I'm going to share with you some of our tools and maps. We use a transitional genogram where we get a sense of the culture, geography, jobs, spirituality, religion. Anybody who doesn't know genograms? Great. We use a transitional field map that Constant showed you, transitional checkerboard that I will share with you, both positive and negative timelines. It's the only time that I ever ask about anything negative, and we don't ask about it as negative. We ask about things that might have thrown the individual or the family off track. But it's as important as knowing the timeline has to include both the strengths and the celebrations and the vulnerable times. We do historical maps and stories, and we do a plan for prevention or intervention planning, because I believe that we all need to be involved in prevention as well as intervention. The family life spiral and themes, strengths, and resources, which include our stories and hierarchies. And we work from the perspective of a hypothetical transitional pathway, that imaginary pathway that takes us all the way from the past to the present and through to the future. And very often what we hear from the past is the despair. And as we get to understand the stories about how people got to where they are, understanding where those strengths are rather than just the vulnerabilities provides a relief and a clarity that allows people to choose the strengths to hand on to future generations, rather than reenacting the negative patterns. So then with the future comes hope. And we do that very formally. We ask for a list of intergenerational strengths, not attached to a particular individual in the family, but what are the themes, strengths, resources that have come down through your family, whether adopted or biological, that you want to see in your great-great-grandchildren. So creating that continuity that bypasses that acute place that they're always stuck in, where it's hard to see a way out. And expanding to that transitional pathway gives vision. For example, we had a couple where the wife was complaining bitterly that there was no hope for the marriage at all. And her husband was pretending not to be drinking, but was losing jobs and coming home extremely drunk every night, very late, not helping with the children. And they were convinced that they had to get divorced. There was no alternative to that. And when we brought in the extended family and they talked about the intergenerational strengths, it was as though a light was shining in the room, because they talked about the challenges that they'd overcome with survivors of genocide, of refugees from various countries, and they talked about all of the religions they came from and how proud they were of those, and the themes of resilience and strengths that allowed them to overcome. And it was incredible watching this couple start to view themselves differently. And the family said, wait a minute, we can hear that a whole lot of this is that the wife is so burdened taking care of the children alone, we'll help. And they had never asked for help. It had never occurred to them to go to aunts, uncles, parents, grandparents to say, could you help while he gets treatment? And just that expansion of the view, the expansion of physical, emotional, and historic resources, changes the way of looking at from despair to hope. Constant showed you the, I love his animated version. I've asked him if we can use it. And this is just looking at it in a little more detail in terms of what we need to consider. And this is whether we're doing prevention, intervention, assessment. is really being aware of every level, biopsychosocial, cultural. So we look at the individual biological system. What's going on biologically? Is there a physical illness that hasn't been diagnosed? Is there something that's happening that has led to the depression or the need for self-soothing with drugs? The psychosocial system, so we're looking at individual response. Then we look at what's going on with the family and intimate natural support system. How is the family responding? What's going on with all of them? And how is that feeding into what the individual is experiencing? Is there a family member who's been diagnosed with a critical, life-threatening illness that is drawing them away? And then our extended natural support system. And there we sit as therapists, physicians, members of the ancillary or artificial support system. But when we're working in prevention, we're in here as natural support system. So what I would love to see us do is narrow the ancillary part, the specialty hospitals, the need for us to repair things. And if we work enough in prevention, we can expand this area and have less need for that. And then we're all embedded in the cultural systems and the natural evolutionary ecosystems of the natural world, which right now is impinging a great deal. As there was, I don't know if you saw there was a memorial ceremony for the glacier in Iceland that has died. And we're looking at some very major shifts that we have to be aware of as we look at how we can help individuals and families. So it's what we call a transitional field map, and we use it for assessment because then I don't forget to look at the different levels, and also for who do I need to collaborate with? You know, who's missing in that system who might shine a light on something that we're missing? And then, is it family members? Is it neighbors? Is it a teacher? Is it a sports coach? Or is it, is it somebody to help with ADD? You know, is this an undiagnosed ADD that has never been dealt with? Or is our young man smoking an enormous amount of pot and becoming psychotic because of that, rather than automatically diagnosing schizophrenia? So this was just to give you a sense of what happens when we use this map in community. This was the map that we did. I was called into New York the day after 9/11 to help with reconnecting the community in Lower Manhattan. And this was the map that community put together with me. So if we look at this from a community perspective, we have all of the biological and individual biological organisms and individual systems with all they were looking at, a lot of them identity, self-image, many of them were grieving, a lot of them were out of their homes. So looking at integration, coping skills, grief and loss, what did this all mean? Because it was a loss of innocence, a change for the first time of the US feeling vulnerable, as opposed to countries like ours, where we grew up in war zones. So looking at each level, affective response, cognitive response, and then really examining what was happening to the families. Were some cut off from others? What were the number of transitions impacting them? And the themes and traditions, loyalties and legacies that would help them rebuild. And then, and physical support, because our resources are both physical and emotional. And the way that we get through major transitions is by relying on our resources as our tools. And the reason that we are thrown off track if there are 3 or more is that Can I ask you to play with me for a second? Okay, if you'd close your eyes and think about, first add up the number of transitions in your immediate family, and your friendship circle over the past, let's say, 6 months to a year, because we're just looking at that counts as recent transitions. If there's been a major loss of a patriarch or somebody that is still reverberating in the family, you can include that even if it's from long ago. I'll give you a minute or two. Just open your eyes when you've done it. Okay, we're just going to do this very roughly. One or less, put your hands up. Two, 3, 4, 5, 6, 7, thank you, 8, 9, 10, more than 10. So we all fall on a natural distribution curve, and this group peaks between 4 and 6, which is 5. The average population peaks at 3 anywhere in the world. And for some reason, those working in mental health addiction, we peak at 5 to 6. So we're right there. We don't know why. Is it because we were the natural helpers to our own families? Is it because our families went through a lot so that we're used to dealing with it? Lots of hypotheses. I haven't found, trying to catch a student to do the research, but we haven't managed yet. But what's really interesting, in an area, I've worked in a number of war zones and mass disaster areas, and in those, at the time, during whatever disaster it is, guess what the community peaks at? How many transitions? 10 anymore? Up. 12 to 14. And the professionals, 14 to 16. Think about homelessness, lack of food, loss of relatives, possibly complete loss of country, right? And the challenge, well, we're going to do one more little exercise. I want you to choose any one of those transitions. It can be a celebration or a challenge, and add up the number of tasks that have been added to your daily schedule because of that one transition. Close your eyes again. Choose any transition that you listed in your numbers. Okay. How many added one task? 2, 3, 4, 5, 6, 7, 8, 9, 10, or more. And now we have almost as many at the 10 mark as we have at where the peak was in numbers. And the reason that's significant is I started to try and find out why is it that 3 or more transitions throw people off track. And it's a balance of resilience, a balance of resources and challenges, right? Stresses and resources. And those can be measured by what resources we have. So let's say we take a young man who's been promoted at work and he's really excited. And now his young wife, he used to drop the children at daycare. But he's not there anymore. So his young wife is dropping 2 children at daycare to go off to her own job, but she's also got an infant who she takes with her to work. So she's now added an extra loop, right? She's already got an infant and 2 little ones, one of whom is going to start kindergarten soon. So she's dealing with a couple of additional transitions. His promotion is a celebration, they get more money, but he's also away more. She's added driving the children, and she's coping. And then his mother gets ill, and she has to go and do a circuit taking care of his mother. So those extra tasks, if he had a sister living in town who could help with mom, if she had a neighbor who could take the kids, her stress level wouldn't increase. But with those additional tasks, without the matching resources, and they don't have the money to buy, to hire somebody to help. The money, the financial resources, the human resources are directly related to how we cope with those transitions, which is why in most parts of the world, 3 or more transitions throws us off track. And when we're thrown off track, our bodies, our minds need to try and equalize. And that means more self-soothing with whatever mechanism we have for self-soothing. So anytime you add up transitions and tasks with one of your new admissions, your new clients, you'll find that imbalance. And the simplicity of getting them reconnected to a support system, or connected to a support system for the first time, helping to find those additional resources, it's very simple, but it makes a huge difference. So let's take a quick look. I've just brought one of our genograms. You all know what a genogram is, so I don't need to go through these. And you'll have the slides. So this was a 24-year-old. It's just a very simple genogram. 24-year-old who was arrested for driving under the influence. And actually, this was one of the cases at Star, many years ago. He had been arrested, started cannabis at 13, started drinking at 15, recently broken up with his fiancée, who he really loved. When we looked at the family story, he had 2 younger sibs, Colleen and Greg. His father, Josh, who was not drinking any longer. I hate the term dry, but we use their words. He had not been drinking for 10 years, but not had any treatment. And when we looked at when we're talking about the story of alcohol in the family, he described his mum and his dad as alcoholic. When we started looking at transitions and events, Josh was 6 when his little brother Terry ran out into the road and got killed, age 3. And Josh felt responsible because Mom had run into the kitchen because the kettle was boiling and said, just watch Terry. So this 6-year-old felt responsible for the death of his little brother. And that was when with that death, that untimely death, Father started drinking and Mom got severely depressed and anxious. Right? So looking, and this is just 3 generations, and similarly, Mom had been, and she was what we call the first caller. Roy was our person of concern. And what happened with Michelle was her father was an alcoholic who had died from a stroke after many years of being bedridden. And she and her mother became very close, taking care of him. And they had also lost a stillborn child. So these two got together. They had not, neither of them had really got over the losses and the grief, which meant that when we don't complete adolescence or any other life cycle stage, we don't successfully complete the next one. So their marriage had never been successful. And they ended up getting divorced. But just, taking that, even just going back 2 generations, helps us understand what's needed. And when we went back more generations, more became apparent. So what happens during stress? Family roles become confused. So if we look at what happened with little Josh, and then with Roy, in the old days, and in some communities still, we have grandparents, husband, wife, who may also be father, mother, and siblings. And the dashed lines are because the boundaries are semi-permeable. Some stories go up and down, some are kept as, quiet between 1 or 2 levels of the hierarchy. If in a traditional extended family, one of the parents, here it just happens to be dad, one of the parents goes away or is ill, it might be a grandparent who comes in to help fix the roof or take care of the kids. In many, many families today, we're not seeing the grandparent level anymore. So if they're not there, what happens is that one of the siblings steps up. Now, there's almost not a family where a kid isn't at some point asked to watch your little brother or help make the bed. The challenge is when that parent, whether it's mother or father, is away for a longer period of time, one of the sibs moves up to the parenting position. And for example, with Josh, he was 6 years old. How could he become a partner to his mother? Right? Because father was away drinking. And so mom is depressed and he steps in trying to help. Now, even if there is no issue in the family and there's an extended absence of a parent, that kid can move up to help, often creates a battle with the other siblings, and if the absence is extended, might become a partner to the remaining parent, hearing the stories, becoming a confidant, and if there's been a grief and loss or impending divorce, might even start to console the remaining parent, moving up to the grandparent generation, taking care of mom or dad. And we see this all the time in families struggling with addiction, that those traditional hierarchies are lost, that kids are up 1 or 2 levels, And when a little one is pushed up to a level like this, they're not trained. And how do kids discipline? They hit, they demand, they yell, because they're not trained. And if that missing parent has been missing for a long time, they've had no modeling, no training at all, and when they become parents, they have no idea how to do it. And they do it as an incompetent child. And the other dynamic that happens with that is they never feel up to the task. They haven't been trained, they're out of their depth, and they're failing. So they grow up with that, overwhelming sense of inadequacy and failure. So just, these are very simple tools, and they're very easy to do, and the families love them. So, and then, of course, let's say mom remarries or dad comes back in and finds a little cuckoo in the nest and says, "What are you doing up there? You belong down here." And mom says, "Wait a minute, he's my helper. He's been wonderful." And then we see marital conflict and divorce. These are the transitional family therapy protocols. Linked community resilience is across a community. The life model is working with groups of people impacted by a problem. Adolescent and family is a 16-session intervention, outpatient intervention, and then Arise Comprehensive Care with Intervention focuses on individual and family. And they all work through family and community links as natural change agents. So this was a community intervention. This was in Romania, where we have the juxtaposition of the haves and the have-nots living in communities right next to each other. And the problem focus was that adolescents in the community were struggling with substance use disorder, drug dealing, and there'd been several deaths. So, just start thinking as I talk about your initial assumptions and hypotheses, and whether you'd need to find, what you'd need to find out about the adolescents, the families, and the community, and what you'd be asking about, what you'd be looking for. So in this one, when I started asking, and I asked for photographs, this was a photograph that got brought to me of where the kids were dying. This is where this community with all the deaths was, and here we have the railway line running right through. And what do you think was on the other side of the railway line? The other community with all the schools, the shops, the hospitals, the clinics. And there was no way. The kids had to cross the line to get anything that they or their families needed. So when we met with the whole family, the focus being on prevention of violence, addiction, and death, the links were everybody in the community, parents, teachers, etc., etc. And the result was that the community groups got together and petitioned the government for a bridge and brought about change, which resulted in no child deaths the ensuing year. And the piece that really was quite incredible was these families hated each other, they didn't trust each other. They made an arrangement to start having kids visit from the wrong side of the tracks and vice versa. I mean, if parents who were horrified by what was happening on the other side let their precious child go stay there for a night. And they started forming relationships and put together this incredible plan and petition and got it. So the power of community is just incredible. So we build on the strength of the community, on their intrinsic resources. We draw on members of the natural support system to form a network committed to helping, and professionals coach community links. So our certified link interventionists use a 3-stage process, bring the community together, select the links, and the links take over the process and we withdraw. And we have a specific pyramid map to enter the community. And, you know, these are just some of the things that communities do. And it's been overwhelming looking at the resilience in communities that people have written off. Post-war Kosovo, they got together and totally redesigned health and mental health and addiction services. And within 2 years, the compliance rate of individuals with schizophrenia and their families was 98% taking meds and coming to treatment. Just amazing stuff. In Argentina, within 2 years, they had a 400% increase in young substance abusers being brought into treatment by their families. The life model, I'm just going to go, is the working with groups. The pilots were mainly with women with HIV and their intimate partners. And then we did, Monomittal did a large pilot through NIMH where the focus was on individuals with HIV and the troubled person serving as a link to the family. And the next one was a focus on abused inner-city minority women, so intimate partner violence. And the aim was to reduce the risk. And the links were the abused women serving as links to their families. And there was an increase in positive conversations with family members and the way they interpreted their stories. All of them had an increased sense of self-worth and self-advocacy. They increased condom use, increase in conversations related to the practice of safer sex, and the women experienced major reductions in physical, emotional, and sexual violence. It's just incredible when one's able to have people feel good enough about themselves to take action and use their resources rather than blaming them. I'm not going to go, we've gone through transitional family therapy. Here again, with the transitional family therapy compared with treatment as usual, both the children and the families showed a tremendous increase in health. And ARISE, the focus is on individuals and families suffering from any progressive, relapsing, chronic and or life-threatening illness. Many of the communities that are using it use it for addiction and mental health. And the links are first caller or contact. And the ARISE support network is members of the entire family, community, and relevant professionals. And it begins with the first call or contact, continues for a minimum of 6 months. Many of the families will go on for a year or two, and we'll get calls 5 years later saying we've had our family, they go on doing their family meetings without us afterwards. And I had one recently, 5 years later, saying we've had a question in our family meeting. Could you join a family meeting just to help us resolve this? And they keep working. And it's evidence-based, best practice, can start at any point during treatment, pre-treatment, if a person's in treatment and wanting to sign out against clinical advice, because the family is there and mobilized and helps them do what they need. It supports healing not just of the individual, but of the entire family. And it works through family and individual motivational interviewing. And it's a process, not an event. And it continues until everyone is healthy, with a focus on cost effectiveness. The more the family does, the better the results. And one of the focuses is changing the family perspective from pathology to health. So the process is comprehensive care. If at any point from the first meeting there's a need for an intervention, we'll go into invitational intervention and back again into comprehensive care. Families are absolutely critical for long-term recovery. We know that they keep people in treatment, and family data with family treatment, as Constant mentioned this morning, the data is way more impressive than individual. Individual works, couples works better, family works best. And Fernandez and his team looked at why the ARISE results are so much better. We have, let me just see if that slide is there. It is. So what he concluded, he compared all the forms of intervention and basically said that we have the family and the support system become a board of directors, so no one person can drive the process in any direction. It has to be a consensus. And it relies on the inherent strength, motivation, and resilience of the family, focuses on healing individual and family, and is invitational and motivational. And what was really exciting was they identified the factors that we built into designing the model. And the NIDA study, which was done in an inner-city nonprofit as well as a for-profit IOP, we had 50% in treatment within 1 week, 76% within 2 weeks, 83% within 3 weeks, and at informal follow-up, 96% within 6 months. And the most significant predictive variable was the more members of the support system involved, the better the outcome. And I'm going to hand over to our STAR team because they replicated our statistics, 62% sober at 1 year with an additional 10% improved. And Christoph told us this morning that it was, what was it, 20%? 20% with DBT or CBT. 20, yeah. And this is regardless of what treatment they received. If the family was there providing a wraparound service and getting healthy at the same time, that was the statistic. And our treatment dropout rates were below 1%, regardless of where people went. And sobriety at roughly 62, and I'm going to leave this. You've got this one in yours, right? The Brandeis? No. You don't? I figured you would do it. Okay, super. Okay, so preliminary data from Brandeis University's independent evaluation of the ARISE service at STAR and Gosnold, and you're going to be hearing from this amazing team from STAR. Over a 2.5-year retrospective of 419 families, over 60% were successfully engaged and retained in treatment through ARISE Continuing Care. They found it cost-effective and efficient, and what I really loved, family members and the addicted individuals spoke highly about ARISE instead of hating us, which sometimes happens. So what about us? In all of this, where do we stand? It's all about Ubuntu. Thank you.